This is the part 2 of our healthcare reform series. Part 1 was last month, and if you joined us then, thank you again for coming back and joining us today. We've got a lot to go over. Hopefully we'll have some time for some questions and answers at the end, and we'll probably looking about a good 20 to 30 minutes here. So let's get started. Again, I'm David Goldstein. For those of you that don't know me, I'm the president of Health Options Worldwide. We're a healthcare IT company that helps to change the delivery of healthcare. So as for those of you that were with us last month, you may recall the Affordable Care Act was not only the longest bill written in the history of the United States, but it's also the most complex one as well. In fact, when you break down all the layers, you find there's really two things in the bill that it actually does. The first is that it provides insurance market reforms. And the second is that it created an individual market. And what I'd like to do today is we're just going to recap some of what we spoke about last time and then go over some current issues, and then we'll head back into how this is going to affect the insurance markets and Medicaid and Medicare. But again, I wanted to make sure the two things that the bill really does, insurance market reforms and an individual mandate. When you look into it, it's really a universal health insurance bill, not necessarily a universal coverage bill. When implemented fully, the Affordable Care Act is going to add additional coverage to about 32 million people, 16 million of Medicaid and 16 million to the state exchanges. Unfortunately, it's still going to leave about 8% of U.S. residents without coverage. So it'll give more coverage to people, but not to everyone, as was intended. To break down the current health insurance market, I guess, in terms of total Americans that are covered, about 150 million Americans receive private health insurance. It's about 49% of the population. And then the government kicks in. About 50 million today, 50 million Americans receive Medicaid, and 43 million receive their health insurance through Medicare. Okay, so why is that really worrying states? Well, in just a few short years, 2014, per the healthcare bill, the states are supposed to have the exchanges up and running. And there's some federal money now to get them operational, but come 2014, as you may recall from last month's webinar, states are then on the docket to pay for this out of their own budgets, and they simply cannot afford them. You know, I think almost everybody knows, if you're reading the papers, almost every state and somewhat every municipality is on the brink of bankruptcy. And, you know, Medicaid, which is partly paid by the feds and partly paid by the states, Medicaid's really taking its tolls on states, and it has to do with the economy. As unemployment has risen to now it's well over 9% nationwide, so has the Medicaid rules. And the reason for that is simple. When folks lose their jobs, in most cases they lose their health insurance coverage as well. Now, without coverage, they go onto the state's Medicaid program and then join those roles. The states are they're almost at capacity. So they're getting really nervous because they have all these extra people on Medicaid. The 2009 stimulus money that was given to them to help them on the short term is going to dry up at the end of the year, and they're not sure how they're going to handle it. In fact, about 33 governors wrote to members of Congress, as well as the Obama administration, asking for relief, asking to get out of some of these healthcare-related federal mandates to alleviate some of their budget constraints. They just can't afford what's being mandated by them. And this is bipartisan, by the way. If you look at California, Governor Jerry Brown, Democratic governor, asked to cut about $1.7 billion from a state's Medicaid program, and to do that, he limit recipients to no more than 10 physician visits a year. And as we're seeing, it's not just the cost burden that's affecting these folks; it's the access to care. Looking over next state over, so almost, is Arizona. A Republican governor, Jan Brewer, she's looking for ways to cut 280,000 people from Arizona's Medicaid rolls. They just can't afford it, and again, unfortunately, the biggest disadvantage comes to the people that need this care the most. Why don't they have access? Why don't they have care? Well, part of the problem is that doctors just aren't accepting or being willing to see Medicaid patients like they used to. They're paid very little in reimbursements, and then in order to get the money from the government, they have to fill out a ton of tedious paperwork, and they just don't feel like it's worth their time. And unfortunately, they're willing to see Medicaid patients. So what does that mean? Well, it means that you have a system that's almost at capacity. You don't have as many providers as you used to seeing patients, and now we're going to get flooded with 16 million more patients. What's going to happen is that people that are on Medicaid today are going to have to compete with the people coming in tomorrow to see the same doctor. And at the end of the day, their care isn't going to be treated as well as it should be. The net result, hospitals are actually going to end up getting majority of these cases as people flood and flock to their ERs, which is undoubtedly much more expensive for the system and much more inefficient. Instead of waiting around in ER for 5, 6, 7 hours to get seen by a doc, they could have just gone to a local physician, in and out, and been on with their day. Something clearly needs to be changed. If left unchecked, come 2019, 93% of the federal revenues are going to be spent on entitlements such as Social Security, Medicare, and Medicaid. This is scary stuff. Looking at Medicaid alone, by 2019, 84 million people are going to be on Medicaid. It's going to cost about $900 billion a year. It's a lot of money. Something needs to be changed. That's why people in Congress are looking at kind of reforming the bill to a more value-based healthcare reform. We spoke a little bit in length last time around on the 1099s. Thankfully, the Senate, back in early February, I think it was about February 2nd, repealed that, which is great for businesses, great for the IRS since they didn't want to handle it, great all around. So we're glad that was done. And interestingly, also, members of Congress are also looking for ways to change the bill. You look over at Senators Ben Nelson and Claire McCaskill. Those two were big proponents of pushing the healthcare reform. They loved it. They wanted it written. They wanted it passed. Now they've actually asked Congress to look for alternatives to individual mandate. The tide is changing, and hopefully Congress will get it right. We'll get a bipartisan package together that's actually going to provide the care that so many people need. Just want to highlight a little bit from where we left off last month in regards to some of the court cases going on in across the country. Actually, last month when we did this webinar, Judge Vinson, federal judge down in Florida, ruled the day before we did this. He ruled that the individual mandate was unconstitutional, and because in his ruling, because it lacks a severability clause, he ruled the entire bill to be unconstitutional. It was a suit filed by 26 states in federal court. Likewise, Virginia wasn't part of that suit. They filed their own lawsuit, and in Virginia, on the same grounds that the individual mandate is unconstitutional. I want to highlight this. It gets a little confusing, and there's been a lot of press about it, so I just want to break it down a little bit. Because yesterday, the Obama administration actually appealed this Virginia ruling, claiming that it's allowable under the Commerce Clause. Just to clear up the confusion real quick, for those of you that aren't familiar with the Commerce Clause, it's what actually gives power to Congress to regulate interstate commerce. It's what gives them the power to tax, to be in charge of any time there's a transaction that deals in between happenings from one state to the next. Congress, the federal government, can be involved in that. It's called the Commerce Clause. With Judge Hudson down in Virginia, in his ruling, he said, yeah, that may be true, but no court's ever expanded the power to Congress, expanded the Commerce Clause in a way to allow the government to regulate a person's decision not to buy a product. And that's where the argument really comes in. Now, the Justice Department's argument on that is they say, hey, yeah, since folks are receiving care from interstate healthcare, the interstate healthcare market, that they need to pay for the services that they consume. That's their argument. But with on the opposing side, with Judge Vinson, Judge Hudson, that have ruled in favor of the states, their argument is, hey, you know what? Can the government force you to buy a good or service, number one, and number two, if you don't buy a good or service, can they fine or tax you? And that's certainly going to be eventually decided by the Supreme Court as to if that's which way that lies. All right, so how does this affect the insurance companies? MLRs, it's called the medical loss ratio for those of you not in the insurance industry. This made a lot of press, a lot of a lot of noise towards the end of last year when Health and Human Services came out and actually ruled on this. Although the medical loss ratio and MLR is simply, this formula might look a little complex, but all it is you take the total number of medical claims, okay, that are out there in a given year. You add to that number the amount of money spent on activities that actually improve the quality of someone's health. Okay, you take that total number, you divide it by the amount of premiums that the insurance company brought in, subtract out all taxes paid, and you come up with your medical loss ratio. And in the Affordable Care Act, for companies, for insurance companies that insure large groups, that's groups with over 100 employees, they must spend at least 85% of their premiums on the medical care, okay, or they'll be required to offer rebates to enrollees. So 85% has to go to the medical losses, leaving 15% to pay for R&D, marketing, profits, overhead, things like that. For smaller groups, less than 100, it's an 80% MLR. 20% can go to the administrative side.